So we have now the second session by Dr. Shigeo Kono. Dr. Shigeo Kono is a remarkable man. He is from the he's the director of the World Health Organization Collaboration Center for Diabetes in Kyoto, Japan. He has since a decennium important courses in the spring every year, and everybody, you know, Stefan Morbach, Jan Appelquist, everybody has been invited. And he founded also the IDF Western Pacific Region Diabetic Footcare project. So I'm very pleased to announce Dr. Shigeo Kono.
Thank you very much for your kind introduction, Professor Barker. And it is a great honor for me to be invited here and to introduce you our data. And first of all, I would like to express my sincere gratitude to the organizing committee of the EWMA for giving me this opportunity. The increase of type 2 diabetes, the number of diabetic foot regions, and the consequently amputation is increasing in Western Pacific region. Western Pacific region has 39 countries and most populous region in the world. And however, there are very few foot care specialists, such as pedologists, podiatrists, as well as footwear specialists like pedologists in Western Pacific region. And there is much ignorance among medical staffs to how to identify those at risk and treat those who develop problems. Furthermore, data about diabetic foot problems in Western Pacific region are very scarce. My talk today consists of 3 parts. Number 1 is a history of international medical collaboration in Western Pacific region. And number 2 is the clinical data of diabetic foot in Western Pacific region. And the number 3 is International Diabetes Federation Western Pacific region foot care project. We launched it in 2011. First, I would like to briefly introduce the history of international medical collaboration with, of diabetic foot care with Asian and Pacific doctors and nurses. Since 2001, we have accepted the doctors from Vietnam and China for practical training of diabetic foot care. We are much surprised to hear that they wanted to study diabetic foot care rather than general management of diabetes. Through the discussion with them, we noticed that diabetic foot problems followed by amputation are increasingly in their countries and getting major concern to cope with rapidly. After the return to their home countries, they opened foot care clinic in their hospitals. Vietnamese doctors opened a foot care unit in their hospital, the National Hospital of Endocrinology in Hanoi, Vietnam. They and WHO regional office asked us to visit them to help them and educate healthcare providers in Vietnam. And in their hospitals, the prevalence of diabetic neuropathy and foot problems was much higher than that of Japan. Furthermore, the average hemoglobin A1C level in the diabetic patients was very high, which worsened the diabetic complication more rapidly than other regions. Since 2004, we have sent our diabetic foot management team to Vietnam periodically and held educational meetings on management of diabetic foot care. I would like to show you the typical foot cases in Vietnam. This is a young diabetic foot patient. He was injured on barefoot walking during working in his field, complicated with serious infection, and admitted. He was hospitalized for 1 month, and when we visited his hospital, he requested the doctors to allow him to be discharged to harvest the plants as soon as possible. However, unfortunately, he had to leave the hospital without any uploading orthotics, but a simple sandal shown here. Appropriate footwear for uploading and protection is one major common problem in our region. In 2006, in order to discuss diabetes and its complications, we held the first international meeting at Kyoto, Japan, with the WHO regional office. At this Kyoto meeting, we invited the doctors from 7 countries shown here in Asia-Pacific region. At this meeting, we also invited Professor Andrew Bolton from the United Kingdom. Through the discussion at the Kyoto meeting this year, we noticed that diabetic foot problems are major and urgent common problems. And so, in 2007, in order to focus upon diabetic foot problems in Western Pacific region, we changed the name of the meeting from Kyoto Meeting to Kyoto Foot Meeting. Doctors from 9 countries such as Vietnam, Indonesia, Malaysia, Mongolia, the Philippines, China, Tonga, India, and Japan attended this meeting. Since 2006, we have held this Kyoto Foot meeting once a year. The next year's Kyoto Foot meeting, 2015, will be the 10th anniversary. Until now, we have invited the foreign experts to Kyoto Foot meeting to give us their excellent knowledge and expertise. We invited from European region Professor Andrew Bolton, the late Mr. Al Foster, and 2 years ago we invited Professor Jan Naprovis from Sweden, and this year we invited Professor Sten Mobach from Germany. We really appreciate for their contribution and help to our Western Pacific region. Since 2004, our team and I have visited many Asia-Pacific countries shown here to exchange our experience and knowledge and hold the educational meeting there for healthcare providers. At Kyoto Foot meeting, the participants collected their clinical data of diabetic foot problems in their own countries and presented for discussion. Besides the discussion of the clinical data at the meeting, we performed several attempts to improve our skills. In 2007, we succeeded to discuss the Vietnamese foot cases with Vietnamese staffs at Hanoi by teleconference using Skype. We discussed how to manage the difficult Vietnamese cases with participants and Vietnam simultaneously. In 2010, we discussed the Filipino foot cases by using Skype with American experts, Professor Benjamin Lipsky at Seattle and Dr. Thomas Ryan at Boston. Despite the market time difference, they kindly taught us how to examine and treat these difficult cases for limb salvage. We have held a practical training course of diabetic foot care for Asian doctors in my hospital, Kyoto Medical Center, along with Kyoto Foot meeting. In 2009, we held a training course for nurses. We invited the nurses from China, Vietnam, and Mongolia and Japan for practical training of foot care, especially preventative foot care. They stayed in a hospital for 1 or 2 months, and we invited the late Ms. Ali Foster from London, UK, to teach them. Ms. Ali Foster kindly helps us to make the video how to prevent diabetic foot in Western Pacific region for healthcare providers in Western Pacific region. At another meeting, we delivered the educational materials of step-by-step project with the kind accordance of Dr. Charles Penze and the educational video of foot care with the kind accordance of Professor Larry Heckles. WHO regional office recommended us to use a website in order to raise awareness of diabetic foot problems amongst diabetic patients and healthcare providers, and consequently save the feet in Western Pacific region. Following WHO's advice, we made up and opened a website. Furthermore, we are uploading our educational materials for foot care, from which anyone can download freely. On these common backgrounds in Western Pacific region, we launched a multinational collaborative study of diabetic foot with our Asian friends, with kind assistance of Professor Andrew Bolton and Professor Benjamin Lipsky. The name of this study is ASIPAC study. We investigated the characteristics of diabetic foot patients and the Charcot foot patients and the lifestyles and behavior of high-risk foot patients and medical cost. 8 hospitals appointed as a central tertiary care hospital and located in urban areas in Vietnam, Thailand, Philippines, Indonesia, China, Mongolia, Cambodia, and Japan participated in this study. Today, I would like to show you some data from the ASIPAC study because I will present data in more detail in this afternoon session. And the characteristics of diabetic foot patients in Western Pacific region were much different in some points. That is a younger age and the shorter duration of diabetes. Males are not predominant. Late presentation, trauma during walking on barefoot or with sandal, bacterial profile, high amputation rate, late diagnosis and proper prognosis in Charcot foot, and appropriate footwear or orthotics are seldom provided. Now, diabetic Charcot foot in the Western Pacific region is also gradually increasing. Characteristics of Charcot patients in our region differed from those in Western Pacific countries in that BMI was lower, and the diagnosis was made later, and the overall prognosis was poorer. It is likely that there are many more hidden cases of Charcot foot that are misdiagnosed or undetected in Western Pacific region rather than other regions. Next, the lifestyles are also much different. A preference of sandals over slippers, high prevalence of foot trauma inside the house, and while wearing sandals outside the house. They believe natural healing, or they can treat foot ulcer by themselves. They can buy antibiotics without prescription. Late consultation with very advanced and complicated foot problems. Indeed, prevention of diabetic foot ulcer is very important, but in our region, most of the patients don't come to the hospital periodically, especially for prevention, because of the economic problems. Then, except the prevention, what is the target for any better change in the Western Pacific region? By analyzing our regional data, we have reached to some conclusion and proposals shown here that we should control diabetic foot infection much more effectively and make up the footwear which the patients felt comfortable and want to wear, and organize a network system for consultation and referral. In 2011, IDF Western Pacific region decided to launch a regional foot care project to reduce amputation rate and improve the patient quality of life. For these purposes, we began to organize a network system of diabetic foot care in our region. At first, we surveyed the system of diabetic foot care in Western Pacific region by using the same questionnaires. 9 countries shown here responded to the question. Although many countries don't have national registries and have accurate data of amputations, some countries, such as Fiji, showed high amputation rate. All of the countries don't have a national center for diabetic foot care. As for nationally recognized training programs, several countries have a training program for diabetic foot care. The duration of the training course is from 16 hours to 3 days. However, basic care are provided to diabetic patients. Most of the Hong Kong and New Zealand have, as for the podiatrist, Hong Kong and New Zealand have podiatrists, but any other country don't have podiatrists, and most countries don't have educational system for podiatry. Instead of podiatrist, who provides a foot care? In a region, nurses play a pivotal role in foot care and management. As for the funding for training course, in many countries, the pharmaceutical companies financially support healthcare providers for training course. And so every time the funding problem is a central problem in all over the world. At the beginning of this project, we made up the action plan of this regional project in 2011. Our action plan at the first time in 2011, we will recognize a core hospital of diabetic foot care as IDF-WPR recognized diabetic foot centers, and organize network system of these diabetic foot centers to support together, inter or internationally. And we will evaluate regional characteristics of diabetic foot in our region more precisely through this network. And we will develop regional clinical guidelines directly applicable to the regional lifestyles and conduct health promotion with WHO and South Pacific Committee. In this regional foot care project, we have held an educational training meeting in Fiji, Singapore, Indonesia, Cambodia, and Vietnam. The first IDF-WPR foot project meeting was held 2 years ago in Kyoto, and we invited Professor Jan Appelqvist for educational lecture. Despite his very tight schedule, he kindly accepted our invitation and taught us a lot about the latest knowledge of the wound care. At the same time of the first project meeting, we held a training course of diabetic foot care for doctors. 7 doctors were invited from Cambodia and Indonesia in 2012. After reviewing process by IDF regional board members at IDF-WPR Council meeting held in Kyoto 2 years ago, we approved 12 hospitals in 10 countries, shown here as IDF-WPR diabetic foot care centers. There is a list of the name of the hospital in each country which were approved as IDF-WPR DFC. The second project meeting was held on March last year, and 22 doctors from 15 countries attended to discuss diabetic foot problems in Western Pacific region. We invited Professor Carlo Carabaggi from Milan, Italy, and Professor Mark McGill from Sydney, Australia. In 2013, 7 doctors from 7 countries attended this training course. In this February, we held a third meeting and we invited Professor Stefan Moberg from Germany. He kindly told us a lot about the certification of the diabetic foot care system in Germany. Through the discussion at this project meeting, we decided to collect the clinical data of diabetic foot patients through this network system by using the same database. Now we are finalizing the database, and we'll begin to collect the clinical data soon. And by analyzing our new regional data, we have noticed the gradual change of the etiology of diabetic foot problem in Western Pacific region, shown here. That is, diabetic foot patients have more ischemic problems, more serious comorbidities, and getting older. Fortunately, smoking rate seems to be declining, but remains still high in Western Pacific region. We have released to some conclusion that we should screen and manage PAD, diabetic foot infection, and comorbidities, make up more comfortable footwear for the patients, and organize a network system for consultation and referral. This is our action plan again. Number 1 was already finished. Through these core centers we approved, we will evaluate regional characteristics of diabetic foot in Western Pacific region more precisely and develop regional clinical guidelines directly applicable to the regional lifestyle. Thank you very much for your kind attention.